Since Tepluzimab was approved in the States, it's been like an earthquake and everyone has got interested in screening.
So you have come up with a pre-screen test that will assess your genetic risk to type 1 diabetes.
Yeah, exactly. And for the first time, now we don't need to get that clue from whether or not you've got a family member affected. We can actually look directly at your risk genes.
I understand that the test is on a biochip.
Yep, that's right. Yeah, so the biochip essentially has 10 spots on a tiny little well. And each of those spots corresponds to one genetic variant associated with type 1 diabetes. And the Randox biochip measures all of those at the same time. And then you compute the risk based on those 10 key genetic variants. And we think up to 50% of people, up to half of people with adult type 1 diabetes, they get initially labeled as type 2.
Wow.
And they don't get insulin treatment. And they run that risk of severe complications. So one of the things is that antibody screening is expensive, and you can target the antibody screening to the people most likely to get type 1 diabetes. And then the benefits of screening are reducing the severity of presentation with type 1 diabetes. So we know just by knowing you're at risk, your chances of having life-threatening diabetic ketoacidosis, they fall dramatically from around 40% in the US down to around 5 to 10%.
So what did we learn? We've learned that diabetes is critically important because you need fuel. And if your insulin key card is destroyed, the fuel can't get to your liver, can't get to your muscles.
Yep. And you can't survive without that insulin.
This week, we have Professor Richard Oram here from the University of Exeter. And Richard is a specialist in diabetes. So we're very privileged to have you here today. Yeah. Your CV is quite extensive. I understand that you got your undergraduate degree at Oxford. Yep. Can you tell us a little bit about yourself and what brought you to this incredible journey of diabetes?
So as you highlighted, my medical training was in Oxford. And after that, I moved to Exeter and trained as a physician, looking after people with kidney failure. I also then undertook a PhD in the biology of type 1 diabetes. And that was really motivated by the patients I'd seen on our kidney unit. Some of the youngest, most unlucky patients that I looked after with kidney failure were people the same age as me, with type 1 diabetes and kidney complications of their type 1 diabetes. And they were either on dialysis or having kidney transplants or kidney and pancreas transplants. That was what led me to do my PhD in type 1 diabetes, and has ultimately led me to mainly focus on research into the biology and genetics of type 1 diabetes.
So kidney failure, what are the symptoms of kidney failure? So when you were impacted, what were you seeing?
So kidney failure, interestingly, only reveals symptoms sometimes quite late, and we pick it up by blood tests with some of the toxins that you would normally remove being measurable. As you head towards your kidneys not working at all, you can develop symptoms such as itchy skin. You can develop nausea or reduced appetite, and often people lose weight. People can develop a severe anemia, and that's particularly common in people with diabetes.
And diabetes is what we're here to talk about today. So I thought that it might be useful if you were to share what are the symptoms of diabetes. Like, why do I not want to have diabetes? Why do I want to prevent diabetes?
There are two major groups of complications for diabetes that are the reason you don't want diabetes. When you present unwell for the first time, often you can run into severe acute complications, as they're known. That is when the blood glucose is very, very high. In type 1 diabetes, you can often develop very acidic blood, and the combination of the high blood glucose and very acidic blood as a result of that can see you being admitted to the intensive care unit for intensive treatment. And rarely, actually, this can be life-threatening and people can die with that acute presentation. The second aspect to diabetes is really that there are long-term consequences to not being able to control your body's blood sugar. So having high blood sugar over years and years of life leads to long-term complications. As we've already discussed, one of those long-term complications can be kidney damage and ultimately kidney failure. But also it can affect the eyes, and people with diabetes run the risk of blindness in the future. That's why they have regular eye checks.
Wow.
It can affect the nerves, so people can end up with nerve damage, particularly in their hands and feet. And then diabetes can affect the cardiovascular system, the large blood vessels of the heart, the brain, and the periphery of the body. And those long-term complications, mainly a result of long-term high blood glucose, are the reason diabetes costs our healthcare systems so much money. For example, here in the USA, the bill that we would pay for the complications of diabetes runs into nearly $20 billion.
I know that in the USA we have about 37 million people that have diabetes,
Yep.
10% of the population,
Yep.
with 1.5 million in the US with type 1 diabetes.
Yep. Yeah.
And I understand that in the UK we have about 5 million
Yep.
people that are suffering from diabetes.
Yep.
So fundamentally, we really want to prevent diabetes.
Yep.
Perhaps you can tell us a little bit about the difference between type 1 and type 2 diabetes, just as a general outline so that we know what we're talking about.
So type 1 diabetes is an autoimmune disease, okay? So it's where our body's immune system goes wrong. We rely on our immune system to defend us against foreign bacteria or viruses. And our immune system has white blood cells. You can think of them like kind of soldiers in our bloodstream, fighting off infection, also cancer. But those soldiers can go rogue. And when they go rogue, they can attack our cells. And in type 1 diabetes, they attack the insulin-producing beta cells in the pancreas. And it's the insulin those beta cells make, which is absolutely critical to the control of blood glucose, okay? So in type 1 diabetes, your beta cells are destroyed, you don't make insulin, or you don't make enough insulin, and you cannot control your blood glucose, okay? That's type 1 diabetes.
Okay.
Do you want me to talk you through type 2?
Yes, if you don't mind.
So in type 2 diabetes, it's not so primarily a disease of destruction of those beta cells, okay? It's really that our body doesn't respond to the insulin we make, okay? Type 2 diabetes actually is slightly more common in adulthood compared to type 1 diabetes that can occur at any age. And type 2 diabetes is associated with the Western lifestyle, with the increasing prevalence of obesity and a resistance to that hormone insulin rather than a deficiency, okay?
So you and I have been talking about a metaphor.
Yeah.
We spent a couple days thinking about this, right?
Yeah.
And I think you've come up with a great little analogy to help me understand the difference, actually, because I think it applies for both type 1 and type 2.
Yeah.
Do you want to
Yeah.
share and specifically help me understand the insulin-producing beta cell?
Yeah. And what the insulin does.
And what the insulin does.
Your
And what
question
the
was-
insulin is like.
Yeah. You were like, Richard, what does insulin do?
Yeah.
And so you could think of glucose as this essential fuel. When we have a meal, we absorb glucose and our blood glucose goes up, okay? And insulin is released in response to that. And you could think of insulin like a key card, okay? That glucose comes in and people in the corridors of a kind of hustling, bustling office that's got, a huge amount going on in all these offices. You've got the people in the corridors, but they need this insulin key card to get into the offices and do the work. And that in type 1 diabetes, there's no key card, there's no insulin. And that glucose in the bloodstream, those people in the corridors, they can't get into the offices, to the places that matter. And that glucose, that energy can't get into the liver, the muscles, the fat, where we store our energy, okay? Does that make sense?
Yeah, that's brilliant. So let me see if I got it, okay?
Yeah.
Glucose is fuel.
Yep.
And without this fuel, we can't survive.
No.
And the fuel is akin to people.
Yeah.
In a high security building.
Yeah.
Right? And these people have jobs to do.
Yeah.
Right?
Yeah.
They're the fuel.
Yeah.
They need to get into, each person needs to get into a particular office.
Yeah.
And they have key cards that get them into that office.
Yep. Yeah.
Insulin is the key card.
Yeah. Insulin is the key card, exactly.
So if our security forces kill people, that's bad. Or if the key card doesn't work, that's bad.
So with this key, the soldiers in this metaphor that we're working on destroy all the key cards. you have no key cards. In type 1 diabetes, your immune system has destroyed them all by destroying the beta cells.
Gotcha.
Okay. In type 2 diabetes, you've got key cards. Yeah. But like when we're in the hotel and it stopped working, our body just isn't recognizing the key card anymore. So you've got insulin, you've got the key cards, but you still can't direct the energy into the right place because your body's not responding.
They need reprogramming.
Yeah.
That's type 2.
Yeah.
Type 1, no key card.
No key cards.
Can we prevent losing our key cards?
Well, that's the million-dollar question.
Okay.
Okay. By the time your blood sugar is high and you're presenting with the symptoms of diabetes, which include feeling really thirsty, needing to go to the toilet a lot to pee, losing weight and feeling generally fatigued. By the time you've got those symptoms, by the time your blood glucose is high, you've already lost a lot of beta cells. But those rogue soldiers of the immune system that were destroying the beta cells, they've been there for quite some time. And actually, quite commonly, the process of autoimmunity has been going on for months and months, if not years and years, without beta cells being destroyed enough that you've got diabetes. And that offers you a window. If we could identify people at that time, before they get diagnosed with high blood sugar, you can stop the immune system in its tracks and you could potentially prevent type 1 diabetes.
Okay, so I think we got it here.
Yep.
So what we're saying is the beta cells are the key cards.
Yeah, or they're making the key cards.
They're making the key cards.
Yeah.
And so we have an opportunity to prevent the soldiers from either killing the beta cells,
from killing the beta cells,
make the key cards.
Yeah.
Okay. And what is that opportunity? How are we going to prevent these rogue soldiers from going in and killing our insulin producing beta cells?
Yeah, sure. And to continue our soldiers metaphor, it's like handcuffing the soldiers so they just can't do their job. They just can't do this. Okay, so effectively,
the rogue soldiers.
Yeah,
handcuffing the rogue.
Handcuffing those rogue soldiers.
Okay.
And if I was to go back to a medical description of that, it would be immunosuppression. It would be suppressing our immune system. And we've been suppressing the immune system for various diseases for decades and decades. And we've been trying with type 1 diabetes to suppress the immune system for decades and decades. But it was only last year, November last year, that the first therapy was FDA approved to be given in early stage type 1 diabetes. So there's been a shockwave through the field of type 1 diabetes in this last 6 months, in this last year.
Is that Tepluzimab?
Yeah, Tepluzimab.
Tepluzimab.
So that effectively is an immunosuppression drug.
Okay.
It was given to people before they presented with clinical type 1 diabetes, and it delayed onset of type 1 diabetes by 3 years, okay?
Wow.
So it meant that there was an extra 3 years of life where people didn't have to do daily injections of insulin, didn't have to do multiple measurements of their own blood glucose every day, and didn't have to run the risk of the complications of giving insulin. And so those 3 years are a massive step forward in the field because we've had nothing to date, and now we have one therapy.
Wow.
And whilst it's only one therapy, what's happened in every other autoimmune disease is these therapies have almost lined up like aeroplanes. There's been one, and then other companies have come along and say, well, this is a market here. I've got immune system drugs. We might be able to land one of our own therapies here. And so we've got the first therapy approved, and the optimism from all stakeholders, from people with type 1 diabetes, their families, from charities, from the physicians and scientists who manage people with type 1 diabetes and do the research, is that this is just the beginning.
So type 1 diabetes is genetic.
Yep, that's true.
Is there any other way that you can become afflicted with type 1 diabetes?
It's important to clarify what we mean when we say type 1 diabetes is genetic. Okay. There are some diseases where a single genetic spelling change causes the disease. It's kind of black and white, okay? And that's not the case for type 1 diabetes. Type 1 diabetes is like most cancers, like heart disease, and like many other autoimmune diseases. There are lots of different risk genes which affect your risk a little bit individually, okay? So there isn't one single spelling change that causes diabetes, but our genes affect our risk for type 1 diabetes. The best example of that would be if you have a relative affected with type 1 diabetes, then we know your risk is about 10 to 15 times higher than the background population. So we've known for decades and decades that if you have a family member affected, your risk is higher.
So it is genetic.
So it's got a strong genetic component. Yeah.
Can you acquire type 1 diabetes without having it in the family?
Yep. Actually, interestingly, even though it's strongly genetic, it's only about 10% of people who present with type 1 diabetes who have a family member affected.
Oh, wow. So 90% do not.
So 90% have the risk genes. They actually carry the risk genes, but they don't have a family member affected. And at the moment, there's no way they would know whether or not they have the risk genes, okay? But the reality is that's most people who present with type 1 diabetes.
Well, I'm starting to get a clear picture now. So now I understand. So you have, in cooperation with Randox and the University of Exeter,
Yep.
come up with a pre-screen test, and that will assess your genetic risk to type 1 diabetes.
Yeah, exactly. And for the first time, now we don't need to get that clue from whether or not you've got a family member affected. We can actually look directly at your risk genes, which essentially are the individual genetic changes which contribute to your risk. So we came up with a way of adding those individual components of genetic risk into a single number, a genetic risk score.
I mean, I think the thing that helps me understand it is its weights and balances, right?
Yep.
So let's say, how many SNPs are there in, so I understand that the test is on a biochip.
Yep, that's right.
And so the biochip is able to essentially figure out the key card of each gene.
Yep.
And if it presents as a potential genetic risk to diabetes.
Yeah, so the biochip essentially has 10 spots on a tiny little well, and each of those spots corresponds to one genetic variant associated with type 1 diabetes. And the Randox biochip measures all of those at the same time, and then you compute the risk based on those 10 key genetic variants, okay? And we generate the score from that.
And so that's basically what you guys at the University of Exeter have come up with, which is an algorithm of weights and balances that measures the SNPs
Yep.
on the biochip.
Yep.
And in combining the results, you can create now a red, amber, or green.
Yeah, exactly. So what we can do is we convert that genetic risk into a number that's low, medium, or high. And you could consider high risk, or red, a little bit like having a family member affected. So you carry the risk genes for type 1 diabetes, but you just don't know it. And if you're in that situation, that would raise the question, well, maybe I ought to get an antibody screen, which is the biomarker for early stage type 1 diabetes, okay? If you're amber, well, then you probably have kind of average risk for type 1 diabetes. It's not particularly high, and in fact, you might be reassured to know that you're not in that high risk group. The green low risk group, interestingly, includes the 10 to 15% of people who have certain genetic variants, which are like a genetic vaccine against type 1 diabetes.
Wow.
So when you're low risk, you're 20-fold less likely to get type 1 diabetes than the background population because of a few genetic variants that, for reasons we don't completely understand, actually protect from type 1 diabetes. Yeah.
If you're high risk, you want to determine if it's type 1 or type 2.
So if you're in that red group with high genetic risk for type 1 diabetes, the question it raises is, well, should I get checked? Should I get an autoantibody test? Because then if I did have early phase type 1 diabetes, now with that drug, Tepluzimab, approved, there'd be something I could do about it.
Right.
So it would be really good to know. So if you're high risk, probably you get an autoantibody screen. That's the next thing to do.
I understand there's a lot of misclassification, that there's a significant percentage of people with diabetes that are misdiagnosed and misclassified.
Yeah, absolutely. To kind of repeat your previous question, it was, I don't have diabetes, but is it in my future? Is type 1 diabetes in my future?
Mm-hmm.
And that's when, if you're in that red risk group, you could get screened. Now you're saying, I've got diabetes, but what type do I have? And that's a really good question. And we're only really now realizing how bad we are at getting that answer in clinical medicine. It's particularly true actually in adulthood, because there's a lot of people with type 2 diabetes, as well as quite a lot of people presenting with type 1 diabetes. And the issue is, you don't want to treat people with type 1 like type 2 for the reasons we discussed before. You can end up with severe life-threatening complications. Yet we know, In fact, maybe 50% of people get misdiagnosed. So around 50% of adults with type 1 diabetes or presenting with type 1 diabetes in adulthood get misdiagnosed, get the wrong treatment, and ultimately run the risk of life-threatening complications.
Okay, yeah, because if you get the wrong treatment, you're actually doing more damage.
Yeah, exactly.
You're actually accelerating the adverse effects and the symptoms.
Well, if you've got type 1 diabetes and you don't get insulin, you can't survive. Yep. If you get the wrong treatment, be that getting insulin for type 2 when you don't need it, or not getting insulin in the appropriate manner as type 1 diabetes, you end up with long-term high blood glucose, and that runs the risk of the chronic complications we were talking about earlier, the eye, kidney, heart, nerve complications that I mentioned at the beginning of the interview.
Do you know what percentage of diabetes patients are misdiagnosed?
So the number I referred to just recently was in regard to type 1 diabetes. And it's only recently we've come to appreciate that type 1 diabetes occurs not just in childhood, but also throughout adulthood. And we think up to 50% of people, up to half of people with adult type 1 diabetes, they get initially labeled as type 2.
Wow.
And they don't get insulin treatment, and they run that risk of severe complications.
I mean, that demonstrates an obvious need for
absolutely.
a quick and easy test
Yeah.
that helps you get pointed in the right direction as to whether you have a genetic risk for type 1 diabetes.
Yeah, well, and the thing here is that there's no one perfect measure, okay? So let's say before the genetic risk score came along, I was asking one of my colleagues in the field, well, how do we discriminate type 1 and type 2 diabetes? What they would have told me is that, well, your age of diagnosis makes a difference. We know that if you're diagnosed younger, it's more likely type 1. They would have told me body mass index, your BMI makes a difference. And if you're slim, you're more likely type 1. But hear what I'm saying, you're more likely, less likely. None of those are binary. Yeah. Finally, there's the autoantibodies, you can measure them. But all of those three components aren't perfect, all right? It's a little bit like thinking about heart disease, where your cholesterol affects your risk, your family history affects your risk, your blood pressure affects your risk. In type 1 diabetes, discriminating it from type 2, you need all the components. You need BMI, you need your age of diagnosis, antibodies, and then finally the genetic risk adds on top of that. And so all those pieces of the puzzle offer the best opportunity to get the diagnosis right.
I mean, it sounds like this should be a national test that you get along with your standard other tests.
Yeah.
This genetic risk score it feels like it's the first of its kind.
Yeah, well, I mean, that's the really interesting thing. That's actually the really exciting thing for me working with Randox, because it was actually not that long ago, 2015, we kind of thought up this genetic risk score project essentially over coffee. Literally, I said to my friend, can we just add up all the genetic risk? Can it help us discriminate people with type 1 and type 2? And my colleague Mike said, yeah, I can do that. Let's try it out. And we very quickly worked out that it was useful. We started using it in several settings in the University of Exeter, but we quickly realized, well, other people could make use of this around the world. We received a lot of attention. There's a lot of interest generally in polygenic scores that aggregate genetic risk together for many different diseases, but none of them have really actually been proven to be useful clinically. And what we realized was that we couldn't have everyone sending their samples to us. We'd love to make a test that other people could use around the world in other laboratories. And that's when we approached Randox. We said, look, we think we've got a good test, but we can't mass produce it. We can't make it available to everyone. And that's the point where the Randox team said, yeah, well, actually, we're interested and we think we can do that. And so they're one of the pioneers in this field to make a diagnostic that is a polygenic score that is going to help in kind of two branches of the field of type 1 diabetes. One is, do I have type 1 diabetes in my future? And the other is, I've got diabetes, what's my type? And in that sense, this test genuinely is trailblazing because it's one of the first polygenic scores to be proven to be really clinically useful. And it's already making its way into clinical guidelines.
Well, I think it's super interesting. Let's try to see if we can make it accessible for the average individual, why am I going to take this test? And what is the benefit of this $99 test that could potentially save my life?
So if you don't have diabetes, the reason you do this test is if you're high risk, then you know this is something I've got to think about and it's worth getting a screen for that early phase disease. I probably don't have that early phase disease, but if I do, this could make all the difference. I could get onto early therapy, which could at the moment delay me from starting insulin. And in the future, maybe we'll have more immunotherapies available and maybe I'll be able to push off the requirement for insulin well into the distance.
Right.
So the reason you want to know is you could end up identifying early phase type 1 diabetes and you'd be able to get a treatment which would push back that need for insulin and that clinical diagnosis. Tepluzimab, yeah. Which is, as I said, was approved by the FDA November last year, and it's almost caused an earthquake in our field because it's the very first disease-modifying therapy.
And then if you do have it, you could figure out if you have type 1 or type 2 based on the genetic factors.
Exactly, and that's actually most sensibly, it's probably a conversation with your physician, because you've got to weigh up those other risk factors, but the genetics really matters.
Okay, so before we go to the physician, we've taken this simple test.
Yeah.
It's just a blood prick.
Yep. So yeah, exactly. One of the things we tried to do is make it really accessible, even mailed from home. So the idea is you could do a finger prick, you put it on filter paper, and that can be mailed back to the Randox lab, and you can get your result posted to you.
And I understand that blood prick can be stored for even decades.
Yep, absolutely.
And so you can come back to that many years from now and do other tests.
Yep, yeah.
So okay, so I'm an individual.
Yep.
I take the test.
Yeah.
I either figure out I'm low risk, which I'm vaccinated.
Yeah.
Essentially, so I don't have to worry about it.
Yeah.
I'm medium risk. What is the implication there?
I think with medium risk, again, you've got to think about other things. So if you've got diabetes, if you're in that medium risk group, you need to think about the other factors. The genetics isn't going to push you one way or the other, and it's the other factors that are going to help decide what diabetes type you have, and you've got to think about that with your physician.
So if I'm medium risk, it helps me determine, it makes me want to maybe get the antibody screen?
So we've always got to go back to those two situations. One is type 1 diabetes in my future? The other is, I've got diabetes, what's my type? In the kind of, I'm well, I don't have diabetes. If you're medium risk, actually your risk is the same as the background population. We wouldn't necessarily recommend screening.
Okay.
It's not like you have a family member affected.
Okay, great.
One of the interesting things is there's no public health screening yet in the world. So there's an outstanding research question about whether it's feasible or financially affordable to do antibodies on everyone, to just measure antibodies in everyone, or to focus purely on those people in red at the high risk. But I wouldn't necessarily recommend testing you if you're in that orange group, the medium risk.
Okay, brilliant.
Okay.
So then if I come back with a high risk, now I can narrow in on whether it's type 1 or type 2.
Yep. If you don't have diabetes, you're going to send off the antibody test. If you've got diabetes, sorry, I'm kind of moving over the desk here, but if you've got diabetes, then you can, if you're red, if you're high risk, then you've got to be thinking, actually, am I type 1? Am I going to need insulin? My physician needs to be thinking about that because they're the one who's going to be prescribing the insulin. But I've got to be very mindful that I have a strong risk factor for type 1 diabetes, and that needs to be front of mind when I'm seeing my physician. Okay?
So the test can help you actually go to your clinician and say, hey, I think because this test is a genetic risk score, that we need to be thinking if my diabetes is type 1. And be careful not to misdiagnose me as type 2.
Exactly.
Which could be devastating. Does this translate into pediatrics? Is there a possibility that children who might be presenting as colicky or fatigued or malaise, who might otherwise, the mom might not realize that this child might be at risk for type 1 diabetes? Does this genetic risk score work for pediatrics?
So the genetic risk score works well in pediatrics, okay? Not only that, but this new therapy has caused this earthquake across adult and in particular pediatric type 1 diabetes medicine, it's really raised the question, should we do public health screening? So at the moment, for children, we do newborn screening where we can make a diagnosis immediately and then we can start a treatment. But if you think about adult public health screening or disease screening, say cancer screening or heart disease screening, we often risk stratify people. So we do one test which identifies us as high risk and then we go on to follow-up tests or reflex testing. The question in childhood is, for example, could we add a type 1 genetic score to the newborn screen? Could we know about those kids who are at high risk for type 1 diabetes from birth and then offer them at pediatric well child visits an antibody screen at that time? And so this is an ongoing debate and question in the field, whether we should have nationalized public health screening for type 1 diabetes in childhood.
So this would allow us to take action pre-symptomatic, pre-disease.
Exactly.
And delay some of the side effects.
Delay that onset where you need to be taking insulin injections every day, monitoring blood glucose every day. And there's a huge burden and stress that comes with that. And additionally, you've got 3 more years, you effectively have 3 more years at the moment of high blood glucose and risk of complications. And the more we can push that clinical diagnosis back, the better. And the optimists amongst us will be saying, this is the beginning of the journey. We've got our first drug pushing back the diagnosis. And hopefully we'll have more that push that further and further and further back.
Right, this is the tip of the spear.
Yeah.
And other pharmaceutical companies will start to do their research and the price of Tepluzimab will come down and other drugs will be available that also push back T1 diabetes.
Exactly. And you made a point about the price of Tepluzimab. It's an expensive drug at the moment. The reason for that is there's no screening for type 1 diabetes outside of research studies. And so there aren't any people to receive this. So even though there are 64,000 people being diagnosed with type 1 diabetes every year in the US, most of them, the vast majority of them, don't know they were developing type 1 diabetes because there's no screening.
Right.
There's no screening across the US healthcare system. So if we can introduce screening, then all of a sudden there are lots of people to give this drug to and the price tumbles down. So one of the things is that antibody screening is expensive and you can target the antibody screening to the people most likely to get type 1 diabetes. And then the benefits of screening are reducing the severity of presentation with type 1 diabetes. So we know just by knowing you're at risk, your chances of having life-threatening diabetic ketoacidosis, they fall dramatically from around 40% in the US down to around 5 to 10%.
Wow, that's massive.
And that's separate to then this possibility that you delay the diagnosis. So I think that insurance companies' eyes should light up at the cost saved from DKA, but then also the years they don't have to be supplying insulin, glucose monitoring, which is incredibly expensive.
So just to be clear, when we talk about antibodies,
yep,
we're talking about the rogue antibodies that are killing the insulin-producing beta cells.
Yeah, so
we're going to screen to see if there's those bad guys in the system.
Exactly.
Okay. In your testing, have you had many false positives in the genetic risk score, or is it a very accurate test?
The genetic risk score itself, we almost wouldn't label like a diagnostic test. Remember I said about having a family member affected?
Yeah.
Yep. Having a family member affected is not like having a positive test. It just says, you're at increased risk, get screened. In the same way, having a high genetic risk score, it's not a positive result to a test. It doesn't say you've got the disease. It just says, I've got elevated risk, like I have a family member affected. So if we assumed everyone with high risk had the disease, it would be a very high false positive rate.
Sure.
But we're not saying that. We're just saying, I'm high risk. I probably won't get type 1 diabetes, but as I'm high risk by my genetics, it's worth getting screened.
It's sort of like a collector lane. If you get a high risk, you kind of go into the collector lane for a second inspection. You're not actually saying you have the disease. So,
exactly.
So therefore, you're not actually even saying positives or negatives.
Yeah.
You're saying, hey, these people that have high risk, let's move you over here.
Yeah.
Let's get a second screen.
Yeah.
Let's make sure that you're not at risk.
Yeah.
And if you are at risk, let's make sure we're diagnosing you whether correctly,
Yeah.
so that we're not treating you incorrectly,
Yeah.
creating more problems than we have.
Yeah.
You know, one thing we haven't covered,
Yeah.
and I know it's not the essence of what we're thinking about here, because I think what we're thinking about is pre-screens.
Yeah.
A way to determine on volume whether you have a genetic predisposition to diabetes.
Yep.
And then taking you over to measure you at a higher level, which is the antibody test.
Yep.
Just for clarification, how does that antibody test work?
So the antibody test is actually the way we define early stage type 1 diabetes. And there are 4 antibodies you can measure. And if you have any 2 out of those 4, you essentially, the train has left the station, you're going to get to that endpoint, which is type 1 diabetes. So we define preclinical type 1 diabetes by the presence of 2 or more autoantibodies. If you only have
these rogue cells,
yeah,
these bad guys that are going and killing the beta cells,
yeah,
and or killing the key cards.
Yeah. So if you have 2 or more of the key autoantibodies which recognize different parts of the beta cell, then you have early stage type 1 diabetes. If you only have 1, it's a bit more uncertain, and you will probably end up in monitoring for those antibody tests.
Okay, so I go to my doctor.
Yeah.
I do the antibody pre-screen. If I have 3, I'm toast. If I have 2, I'm toast. If I'm 1, I'm okay.
So if you have 2 or more, you've got preclinical type 1 diabetes, and we're talking about whether or not you'd be eligible for Tepluzimab, okay? If you have 1 autoantibody, then you probably need to go into monitoring to see if you develop 2.
Okay, gotcha.
Okay? And I think it's worth saying at this point, a very reasonable question is, of those people with 2, how guaranteed is it that if we do nothing, they'll end up with clinical type 1 diabetes with very high blood sugar? And what we think is that pretty much everyone ends up in that situation, okay? The best study we have followed children from very early life to the age of 18. And by the age of 18, 85% of those with 2 autoantibodies had converted to type 1 diabetes. And that small remainder, we think, were converting just after the age of 18. But what that highlights is actually sometimes going from the 2 autoantibodies then to the clinical diagnosis can take years. And that's the window of opportunity we're trying to leverage.
And expand with Tepluzimab.
Exactly. Yeah.
How does someone go and get Tepluzimab?
So you'd have to see your endocrinologist, so a type 1 diabetes specialist, and they would then likely refer you on to one of the now multiple centers around the US that are starting to give Tepluzimab.
Diabetes pre-screen test, how do we get that?
So you could apply for it directly yourself. You could go onto Randox's website, order a kit, and do it via the mail.
And we can order the test right there. It's a home test kit. You know, one of the things that we talk about here at Randox Health is that your health is your wealth, that it is the ultimate wealth. And without my health, I've realized that I have nothing. Your health is your wealth. So what did we learn? Is there anything that we've learned? We've learned that diabetes is critically important because you need fuel. And if your insulin key card is destroyed, the fuel can't get to your liver, it can't get to your muscles.
Yep. And you can't survive without that insulin.
You can't survive. We've learned that you can, if you are in the high risk, you can delay the onset of symptoms. Pre-symptomatic, you can push that out 3 years with Tepluzimab.
Yeah. Yeah.
A healthy lifestyle avoids type 2 diabetes.
Yeah, we didn't focus on that, but that's absolutely right. Yeah. And you highlighted we can identify those people who should get screened before they get diabetes. And that other piece we talked about was, I've got diabetes, what type do I have? And then there the genetics can help figure that out.
Yeah, it's super important that if you have diabetes, you rule out type 1.
Yeah.
Is there any country in the world right now that does a general screen for the population for diabetes?
So the short answer is no, outside of research studies. So there's no nationalized public health screening. However, Since Tepluzimab was approved in the States, it's been like an earthquake, and everyone has got interested in screening. So there are screening programs that actually we are collaborating on in Australia, in the Middle East, across Europe, and in particular Scandinavia, so Finland and Sweden, who are top of the Premier League in terms of type 1 diabetes incidence. In the UK, the Canadian government just gave $12 million to start type 1 diabetes screening in Canada. And then in the US, there are multiple programs trying to assess public health screening here.
Well, Richard, what a wonderful experience to have you here with us at the Randox Health Podcast. Thank you again for joining us. And if you're in our audience, come back and see us next week. Thanks again, Richard.
My pleasure. Thanks very much.